Hi there, and welcome to Real Talk, a space where psychology meets culture, community, and unapologetic truth. My name is Dr. Erika Dawkins, and along with Dr. Denise Watkins, we are two Black psych types at different stages of our careers. And we're here to unpack real life issues that impact our mental health, relationships, and resilience in a revolutionary way. From trauma to triumph, therapy to theology, we hold space for healing, growth, and the conversations that we feel our communities deserve. And so this is Real Talk, raw, relevant, revolutionary, and rooted in love. So today's episode is around holding space. It is Suicide Prevention Month, and it's important for us to talk about that in relation to mental health and what it means for our community. So today we are diving into what we feel like are one of the most urgent and often overlooked topics in mental health. And as two Black psych types, we've seen firsthand how systemic barriers, cultural stigma, and generational trauma tend to shape the way that our communities experience and often then deal in silence with mental health challenges related to death by suicide. And in this episode, we're going to share data, some personal reflections, and some community centered strategies to really help us move from silence to support. And so, hopefully, whether you're a clinician, a caregiver, or just someone who cares, that this conversation will be relevant to you. So we'd like to start off by just reminding folks that if you or someone that you know is navigating a mental health challenge and even considering taking their own life, that help is available. You can call or text 988, which is the Suicide and Crisis Lifeline, anytime. Okay. So why don't we dive in to some brief introductions to start us off, especially since it's our first episode. Dr. Watkins, would you like to start?
Absolutely. Hello, my name is Dr. Denise Watkins. I am a recent graduate of Widener University's Institute of Graduate Clinical Psychology, and I am a pre-licensed mental health professional. I am very interested in social justice and working with BIPOC communities. I am looking forward to being a resource to individuals who are marginalized in the state of Pennsylvania. And my goal one day is to hopefully open a nonprofit to further service individuals within Philadelphia.
Absolutely. Welcome, Dr. Watkins, and congratulations on recently graduating and this kind of journey to being a trusted mental health professional in our community. I'll introduce myself. I'm Dr. Erika Dawkins. I am what's considered in our field to be a mid-career psychologist, so someone who is 10 plus years out from graduation. I also attended the Institute for Graduate Clinical Psychology and have been practicing in the state of Pennsylvania for some time, working within the community of Chester, Pennsylvania, also as a assistant professor at Widener University's Institute for Graduate Clinical Psychology, and holding a small boutique private practice in this area that supports folks that are interested in bettering their intra with themselves and interpersonal with other people relationships. And so excited that we get to have this conversation. I think the dynamic of us being at two different places in our careers is going to be helpful, not only for folks that maybe are interested in being clinicians, but also for folks that are looking for support and maybe understanding what they can get within a therapeutic setting. So I think it's important that we recognize, and I think we were talking before we started recording about really the sensitive nature of this topic, and even starting off our first episode with this topic. I think seeing the relevance in terms of Suicide Awareness Month, but also the urgency within our own community. And so we want to acknowledge that at the start. And of course, kind of say that we are going to be sharing some resources not only on our site, but also throughout our time together that folks can access to make sure that they have continuity of care while in crisis and then navigating throughout. So why don't we frame this conversation about death by suicide within our community and kind of give some context to why there might be some sense of urgency within the Black community where other communities might not find it. I'd like to share, maybe start out by sharing some statistics about what we see. And then maybe we can kind of have a conversation about disparities that we've seen in our own practice as it relates to Black individuals accessing mental health.
Absolutely.
So, folks may not realize that suicide is actually the third leading cause of death for Black youth, aged 10 to 24 here in the United States. And for the past 10 to 15 years, suicide rates have actually increased around and among Black Americans by almost 60%. It is the sharpest increase that we've seen in adolescents and young adults across other racial and ethnic demographics. And it is seen that oftentimes the action, both the attempts and successful deaths by suicide, have increased in young adulthood and adolescence and is unlike what we consider to be the US population average, which oftentimes we see more death by suicides in other groups at middle age. And so when we think about just life trajectory, if we've got more Black youth committing or rather dying by suicide at an earlier age, we also do not see advancement of things like families, of living into older age, into being able to create and foster longevity in generations. And so we see then some domino effects of these increased deaths by suicide. Yeah. And I think it's directly connected to mental health. And I'm wondering, Dr. Watkins, can you talk a little bit about things that you saw not only in your training, but maybe also things that you are aware of in terms of things that are disparities within the Black community that maybe lead to what we see in terms of death by suicide?
Yes, absolutely. In my professional experience working in, especially within inpatient community mental health hospitals here in Philadelphia, among the milieu were youth, right? And then there were also adults. And so um, when I was on the units, I would see individuals coming in either because they had either been involuntarily brought in or they voluntarily showed up. And when I saw some of these individuals, a great majority of them were BIPOC individuals. And some of them, unfortunately were not in a place where they felt safe, felt that they were being heard when they were saying that what they were experiencing, especially around passive or active suicidal ideation. Um, I also will say that to some degree, it appears that individuals who are coming forward and saying that they do need help might not be getting the same standard or level of care that an individual who does not identify as BIPOC is getting. There are definitely some stigmatisms around how things are reported through note taking, the way that a individual is viewed because of the color of their skin. They're either uh, deemed as aggressive or non-compliant, when at times they're just struggling deeply, and are looking to be seen and not judged.
Yeah. I think that's an important distinction that's made, and it makes me think about some of the disparities that we recognize, even in terms of mental health treatment.
Mhm.
So thinking about your experience in the inpatient unit, that really only about 39% of Black individuals with mental health concerns receive treatment in comparison to about 52% of white counterparts. And so when we think about not just the whether or not things are being addressed, you mentioned kind of quality of treatment and the supports that maybe individuals have, even in exiting maybe more intensive treatment situations or having more ongoing therapeutic relationships that could impact whether or not someone feels like they have the support to avoid taking their own life.
Mhm.
I think we also know that Black individuals are less likely to receive things like prescription medications or even accurate medications for not taking accurate histories or really having a clear picture of what might be um, happening, or even good education around the benefits of medication or whether medication is necessary in their case.
Mhm.
And then when I think about just some of those structural pieces in terms of structural racism in school and healthcare settings, and even the crisis response,
Yes.
it creates a lot of barriers that really don't lead to successful suicide prevention methods.
Absolutely. Yep. I mean, even taking in consideration how misdiagnosis can also be an issue in that. Just unfortunately, some of the BIPOC individuals that are coming into the community mental health centers are also not necessarily being ascribed the proper diagnosis or given evaluation that would actually capture what it is they're experiencing and what they're needing in order to have the best quality of life once they're leaving. Um, so, yes, I do agree that there are a, an abundance of barriers that would impact the progression and treatment that someone is going to get when they are in need or are experiencing suicidal ideation.
Absolutely. I mean, I think one of the things that feels challenging even about having this conversation is it feels like we are having the conversation more often. I think about social media, and I think we talked about this before,
Mhm.
that there's a lot of talk about people having a therapist or being connected or mental health and even representation in the mental health fields being so important, but we're still seeing statistically less leaning into mental health services when it comes to Black and Brown individuals. And it makes me think about just the historical and intergenerational aspects of that, as well as maybe typically what has been seen as supportive in terms of faith-based settings that maybe have not fully adjusted to be able to capture what is needed for individuals. And I'm curious what you think about either of those as places that we can do better.
Absolutely. As far as intergenerational trauma is concerned, we can talk deeply about epigenetics and, how the impact of the colonization of the U.S. and slavery and the aftermath of those experiences for African Americans have really shaped the approach to treating your own mental health and even your holistic health. Unfortunately, we were resilient throughout the times that were negative for us and in some ways that is positive in that resilience is something that can help you get through some of the toughest things you may experience, but on the bottom half of that, resilience can lead to also like being uh, kind of invalidated in the sense of, well,
Mhm.
you're strong, you can get through this. And, while African American individuals have strength, they also need support in ways that are not just built on the resilience of themselves.
Absolutely. Well, yeah, I mean, I think when you talk about that resilience piece, it makes me think about the relationship to faith-based communities and how oftentimes when folks are having maybe mental health challenges or needs, that the faith-based community solution is either prayer,
Mm.
or seeing, in some ways as the evidence of needing support being associated with sin that needs to be absolved, or, kind of shame in some ways, and not really acknowledging the impact that marrying faith and mental health can provide in terms of relief and support to individuals.
That's
Um, yeah, and so I think it is one of those things that is challenging as a practitioner that maybe straddles both of those spaces, right? The mental health space as well as the faith-based space. But I'm wondering if there is a pivotal moment for you that you might acknowledge that really shaped your understanding of the impact that death by suicide can have in Black communities.
absolutely, I can think to, even some pop culture, individuals, who are public figures that
Mm.
I have seen this happen with. But unfortunately, I've had family members and, friends who have, passed and died by suicide. And it is heart-wrenching to think that someone would feel such an immense amount of pain that the only solution that they see is ending their own life. And unfortunately, in the Black community, it is hard sometimes to be forthcoming and vulnerable about what it is you're experiencing, whether that be because of fear of what might happen next, or a fear of not being heard, seen, or told to find some form of outlet to figure it out. It would be wonderful if when someone comes forward and says those things, that as a community we embrace them and try to help them. Um, but unfortunately, at times, I think some people have such a level of fear of this topic, or such a level of fear that will lead to the person dying by suicide, that they avoid it entirely.
Yeah. Yeah. I mean, I think that I've seen that evidenced in some of the work that I've done in the community. I think about my role as a school psychologist at a local charter school.
Mhm.
And we had our first experience of a student dying by suicide. And I think there were a lot of questions around what was missed, a desire to place the blame, to place responsibility, to kind of come back after the fact and to be able to essentially like problem solve for and correct, in the aftermath, where even supporting students that were trying to process the loss seemed like an afterthought, and thinking about like what we could do even preventatively in the future that could be really helpful. We were so focused on what was missed and who needed to take responsibility, that it seemed, yeah, like it wasn't until months later that we really then started to think about what we could do for those that were left behind, including the family. And I think there's so many things that happen and so many people that can be impacted when there is a loss like that.
Mhm.
But it made me think, as someone who tends to think more systemically, like what is it not only that we can put in place, but what are the interventions and things that we might need to be mindful of when events like this happen, to make sure that we are protecting and supporting every component of a system that is meant to work together to be a community.
Yeah, I really, think that that's extremely important, especially as a new incoming clinician. One of the things that I we will say is that there's, maybe some anxiety about approaching the topic
Mm,
of suicide, especially as someone who's early in their career. And I definitely experienced that throughout my training. In the beginning, I was nervous, but I also learned the use of like assessment tools and the use of being open with a client, being able to bring that up and discuss that in a way where you are validating uh, the understanding of what they're experiencing, but also recognizing, okay, this person is seeking a support, and what are the things that align with their life or that align with their experience that are going to help them maybe come out of the ideation in that moment. And so, I implore anyone who is in the field to figure out a way to be more comfortable with discussing the topic in the room and also making use of tools that are out there, because there are all different types of assessment tools that you can use in the room with the client that can help you then figure out what is it that they need in this moment, what support will help them feel valued.
absolutely. Yeah, I think what you mentioned about assessments is a big thing. I know that the Columbia is a, gold, what we call in the field a gold standard. So a typical, well-used, well-researched way of either assessing what's going on or being able to provide care or intervention, as we would call it.
Mhm,
So in both school settings and community mental health, as well as hospital settings, the Columbia suicide scale is something that tends to be exercised in making a suicide assessment.
mhm,
I think about in my training how one thing that was adjusted over time, we used to lean into this idea of making like contracts and safety contracts. And when you talked about like sometimes anxiety or nervousness that comes with having to do an assessment or having a client that is expressing ideation in real time, sometimes I think we want to hold on to something that feels anchoring and
mhm,
safe, like a contract. But since I received my training, we've actually found that things like contracts are less effective in maintaining an individual's safety. And some of the other things that we've been talking about in terms of supports, finding and making sure that they're both preventative and in real time intervention pieces, understanding community, understanding the person's values, and being able to connect their behaviors back to that are all things that are actually found to be more effective than something like a contract. And I think that's been the biggest challenge that I've been faced with when thinking about work with clients and families is, they want something that's ironclad that they can hold on to ensure safety, and that can be hard sometimes.
Absolutely. Yeah, I have dealt with similar things. At one point, had to co-create a safety plan with the client and their family. And, I thought that that was a wonderful tool, but it was not the end all be all.
Right.
We were having ongoing conversations about things that they saw that either indicated improvement or indicated that this was not working and we needed to try something else. So again, it really helps to amass like a toolbox for you and for your client of things that they can pull from when the time comes, and to have that in their awareness even prior to a experience of crisis.
Absolutely. One of the things that I think we've been talking about is a level of intervention and support or experience of suicide and suicidality generally. And I'm wondering if we might talk specifically about some community-centered prevention and intervention that's relevant for Black communities. Um, can you share from your vantage point what you think culturally responsive suicide prevention might look like?
So, culturally responsive suicide prevention, in my eyes, looks a lot like being thoughtful about the next steps, specifically in thinking when someone is maybe experiencing a mental health crisis. And usually people tend to think, well, I'll call 911. And in some cases, um, that can be dangerous. In many cases, it has been dangerous. Uh, there are statistics about officer involved incidents and murders or killings, that have been directly connected to a mental health crisis, right?
Mm.
And there are trainings and organizations that exist currently that are trying to make it so that those things do not occur. And that's the crisis intervention um, training that needs to be given to not only police officers, but EMS and anybody who would be responding. Um, there is a program out there that exists that talks about how you can take steps and reach out to a crisis line so that you don't necessarily call the police and they show up. With the uh, lack of training that could lead to a death or an injury. Um, so when I think about culturally responsive, I'm thinking about how sometimes biases about BIPOC individuals could put them in harm's way when you are seeking out that care, and how the individuals who are assisting, they need to be very intentional and thoughtful about what they're going to do next and how they want to do it so that they can ensure that the person is safe and that they're going to get the care that is going to bring them forward and not end up ending their life.
Absolutely. I think that makes a lot of sense. And I think it makes me then think about um, culturally responsive suicide prevention in the realm of the systems in which we have in place. You know, across the board, we rarely uh, think about the impact, and kind of trickle down effect of things like education, of training, licensing, and then practice of practitioners. But just to give the example, so thinking about some of the recent changes to graduate education or educational caps and limits. For individuals pursuing degrees in the United States. Well,
Mhm.
those caps may directly impact the number of marginalized or minoritized communities that are eligible to go on to higher education to receive degrees that allow them to practice as practitioners. And we already know that only about 4% of all psychologists in the United States are Black, which limits what we might see as culturally affirming care, even though we know that the research suggests that it's more about relationship than it is about race in the room. But for individuals to feel comfortable in seeking out care, they have to have some sense that the care may be affirming and that they see representation in this space. And
Absolutely.
by people being limited in terms of being able to pursue their education, it directly then impacts the number of practitioners that we have, and then again, may limit help seeking within the community. And so when I think about what prevention might look like in a way that is culturally responsive, it really is systemic. We need people in the pipeline that are not only aware, but are ready to be able to support
Mhm.
things that are coming up and to create communities and systems of awareness around where to go to be able to seek those supports and services. And it makes me think about the way that outside of education, how other institutions might be able to play a vital role in that. Specifically thinking about churches, barbershops, hair salons, schools, and even the social media space.
Absolutely. I mean, I think it's important for us to think about how when it affects one, it really truly affects all of us. And as a community, it is our responsibility to try our best to help those individuals who might be experiencing that. And get them to a place where they're actually feeling their best quality of life. I love the idea of, pulling in even the churches and the barbershops and the hair salons. But I also think that among the Black community, it is very important that we educate ourselves about some of the things that might influence us to withhold that feeling,
Mhm.
right? I think deeply about the strong Black woman schema, and how that would easily, be a barrier for a Black woman, right? I'm supposed to be viewed as very strong, and here I am, admitting that I think that I don't want to live, right? And so these are the things that are important for even the community to understand. But that starts with us even making the information digestible for the community too,
Right.
you know.
Absolutely. Absolutely. How we talk about, and it reminds me of kind of this mantra, that while I feel like I see it less and less in this generation and maybe generations that are behind or, to follow us, but it makes me think about, kind of what happens in this house stays in this house. Don't you be telling any
Mm,
of our business. And even the reaction to maybe feelings of frustration, sadness, hopelessness, in that like you need to go get yourself together, like you don't have enough to, you don't have enough going on where you should be worried about that. Like there are so many other things that you could worry about rather than us really being able to create, like you said, like safe spaces to be able to have the conversations, knowledge about responding in ways that are supportive. And I think in our field, we oftentimes maybe use the language affirming. And I think people get scared because that means that, or they think that means that we're supporting the decision or behavior, but it's more so a space for us to be able to get curious and to make sure that it's clear that we validate that someone's feelings of not being supported or of needing more support or of being upset and sad and depressed are legitimate feelings considering everything that they are carrying and the things that we don't know about. Right. And I think that if we give language and are using some shared appropriate language in all of these spaces, I think about two areas. One, have a colleague, Afia and Billy Shaka, who created this program, Psychotherapy, for barbershops and salons to kind of have first mental health first aid strategies and tactics to support when things like that come up in those spaces, since those are sacred spaces in which we might gather and seek support. But people may not always feel equipped and have the language. So think about that space. And then I think about even what you and I are doing right now, and many other mental health clinicians in the social media space, and saying, okay, if you won't necessarily come to us or have trouble getting to us, how might we provide education and knowledge and language and affirmation of experience in the social media space?
Absolutely. Even open discussion
Yeah.
like this, but with your friends, family, individuals that are trusted in your community, that's all giving way to the destigmatization of all of these things. We also, need to acknowledge that the stigma of admitting you're not okay can be heavy for any individual, but is extremely particularly heavy in the Black community, because again, that resilience that we have had over the last 400 years in this country has really put us in a position where we are seen as highly capable to handle just about anything. But we need to destigmatize that it is okay to ask for help. You can ask for help, and you can seek it in places that you feel most comfortable, whether that be at church, at your hair salon, your local, grocery store. We should have all of these community resources be a place where individuals can feel that they can get what they're looking for if that's what they need.
Absolutely. I'm wondering in your training and, now here in your early practice, if you've seen examples that are tied to like successful either outreach or creation of that space that you think could be replicable or that we should maybe strive for?
Absolutely.
Yeah.
At my local church, they do a conversation about mental health pretty frequently. I believe they do a once a month sit-in where they invite everybody in the congregation to kind of just come in and talk about things that they think are important about mental health, and particularly, especially because this month is Suicide Prevention Month in September, that is the topic and talking about, what would it look like if you were experiencing that, and where would you go? Who would you seek out? So, obviously at this church, you can do the counseling with the pastor, but they also refer to psychological, community groups in the area because there is an understanding that religion is so helpful, a great protective factor, and cannot always be the end all be all, and that it is okay to have, the person that you talk to at church and then the person that you talk to in the therapy room.
Mm.
I believe that Dr. Rita Walker had even touted that in the unapologetic guide for mental health for Black individuals that religion can bring you the person that you need to help you. And so that is just one example that I've seen. And this can be done in many different ways. It doesn't have to just be at the church. It can be in, like you said, the barber shop. It can also be at schools where we will talk about these things with young people and give them the resources because when the time comes, they have the phone number, they have the name of the organization, and they can reach out when they need it.
Yeah. Yeah. I mean, I think in addition to what you mentioned, in being able to like make those connections, I think some variability in expression of need has been helpful in healing spaces. So places where people can maybe come and do something with their hands that allows them to have either release or expression of need, even being able to write it down. Not everyone is going to come to a space and be in a position to feel vulnerable in talking and talking through. But I think I have found in other spaces where people can write out or have some physical representation of what their experience is and put words to it has also created like a successful healing environment. Um, and I think people that are interested in helping, like you said, being very knowledgeable of the connections. I think sometimes we feel like when people come to us, some of our frustration in our response or some of our own angst in responding to them is because we don't feel equipped to be able to help them. And so we get frustrated with that dynamic, and that person might read it as frustration with them and their experience. But I think if we recognize that sometimes people come to us and our responsibility is to refer, to be able to recognize what's happening so that we can make an appropriate referral that hopefully provides us some relief in terms of holding on the sole responsibility. I think looking at it as a community effort can take the pressure off of us to respond perfectly in what can really be very imperfect, messy moments.
Hmm. Yeah, I definitely think that you've highlighted a great point, which is that, that we also have to be willing as professionals to say, okay, this is something that I know someone can handle that I may not. And also using consultation, to your best advantage. If you are working with someone and you feel stuck or you need more assistance, why not reach out to a colleague or reach out to someone and possibly, if that's the person they need to work with, refer them to them.
Absolutely. Yeah. So, I mean, I think one of the things that I appreciate about the ability to have this conversation with you today is I think it's important. Sometimes we get so used to our own approaches or even our limited setting that we don't seek additional support, we don't seek consult. We're afraid to have these conversations. And again, I think I keep going back even to us saying, like, do we want this to be the first time that we kind of introduce this opportunity to have these conversations? And I really appreciate you underscoring the importance, not just in timing, but just as a conversation in general. And so I want to make sure before we wrap today that we do provide some of the resources that we had talked about, both, kind of on a more national level, and then thinking about how we might access local resources, and then maybe some encouragement and maybe final thoughts that we'd both have around, kind of the topic in general.
Mhm.
So, we mentioned 988 in terms of the suicide and crisis lifeline, and that is for folks that are listening in the US. It is an opportunity to be able to speak directly to someone and be connected to support in real time. For folks that may not be interested in, talking with someone or using the text through 988. There is also the crisis text line that extends a little more globally. You're able to text hello to 741741, and that is in the US, Canada, UK, and Ireland. We also have within the United States, specifically for Black, Brown, and Indigenous communities, the Black Line, and it can be reached at callblackline.com,
Mhm.
or you can call or text Blackline at 1-800-604-5841. That's 1-800-604-5841. If you feel like a family member or yourself is also in immediate crisis, you can also go to your local emergency room to be able to be assessed. And depending on where you are, there is an opportunity to potentially call like a crisis or mobile unit before, like Dr. Watkins mentioned, calling 911, because those are trained individuals that can help in times of crisis. There are also some resources in terms of both NAMI or even NIMH in terms of the National Institute of Mental Health that have a lot of information around prevention strategies and intervention strategies. And then you can always use resources like Therapy for Black Girls or Psychology Today to be able to search for mental health clinicians that can support ongoing, because we recognize that while there may be a need for crisis intervention, that the ideal situation is to set up a system of supports for ongoing, just community building and support provision and intervention. And so being connected with a practitioner for that is really important.
Absolutely, absolutely. I think, also when you think about how families and friends and community, it is more than imperative that you check in on your loved ones, right?
Mhm.
Like we talked about with social media, we feel that people are very heavily connected to one another, and you know, people think that thoughts and prayers are helpful, but it doesn't hurt to stop by and see a friend or to call them over the phone or FaceTime, so you can actually see them and see what they look like, see what's
Mhm.
going on, and hopefully that's helpful. But just continuing to talk about these things openly, and you know if you're able, with people that you feel comfortable and safe with, that is great. And then we all have the power to advocate for mental health, and it doesn't have to be a big grand gesture either. It's simple things can be advocating, whether you see someone struggling with something and you have the opportunity to give them a resource, or if you are posting online. These are all ways that you can advocate, in a way that feels comfortable for you.
Yeah, yeah. I think, we oftentimes feel like sometimes issues or needs are so big
Mhm.
that we feel like our part is a drop in the bucket. But if we are holding and passing and continuing to pour into that bucket, it will fill and can be used to water the spaces that we are in. So I appreciate you again pushing for us to be able to have this conversation, to be able to start the conversation. It's definitely, I think, for us, not a place where this conversation will end. And we hope that if there are questions or thoughts or even desire for other aspects of continuing this conversation, that folks will reach out. And we'd love to think about how we can integrate that into the ongoing conversations that we will have.
Mhm.
So we know that today's conversation was heavy and may feel heavy for folks that are even actively having some questioning experience. And we also recognize the necessity of it. Suicide prevention and intervention in our community is something that's going to require courage and compassion and connection and conversation. And we hope that, our time together helped folks feel a little more equipped, a little more courageous, and a little less alone in having the conversation. And so, if in ways you found our conversation meaningful, please share it with someone that you love and share with us the impact that it may have had. We want you to remember that you matter, your experience and story matters. And until next time, we hope that you keep showing up and speaking truth and do the work and know that healing is possible. Yeah. So we'll be back real soon with more real talk. And everybody take care of yourselves and each other. Bye.